Next, we delve into Danon disease, DD. This sounds like a metabolic disorder that affects not just the heart, but also skeletal muscle and the nervous system.
Indeed, Danon disease was first described in 1981. It was identified in two 16-year-old boys who presented with cardiomegaly, enlarged heart, myopathy, muscle weakness, and cognitive impairment. Initially, it was classified as a type of lysosomal storage disease because muscle biopsies showed excessive glycogen accumulation within lysosomes, which are like cellular recycling centers. However, its true underlying cause was clarified in 2000. It's not due to a faulty lysosomal enzyme, but rather a mutation in a lysosomal membrane protein called LMP2.
So what's happening genetically to cause these multisystem effects, heart, muscle, brain?
DD follows an X-linked dominant inheritance pattern. This means the causative gene is on the X chromosome, and because males only have one X chromosome, they are typically more severely affected than females, who have two X chromosomes, one potentially normal copy. Some de novo mutations are also reported. The causative mutations occur in the LMP2 gene. This gene encodes three protein isoforms involved in autophagy, the process of lysosomal protein degradation. All known pathogenic mutations affect the LMP2B isoform, which is predominantly expressed in tissues like the heart, skeletal muscle, and brain. This explains its widespread effects across these systems due to impaired autophagy and cellular waste clearance. Symptoms tend to manifest earlier and progress more rapidly in male patients. Approximately 90% of affected males develop proximal muscle weakness, weakness closer to the center of the body, which gradually worsens, though it's usually not the primary cause of death. Myopathy appears to affect only about 35–50% of females. In one study, 88% of males and 77% of females were symptomatic. Palpitations are the most common symptom, followed by chest pain.
Patients may also experience breathlessness, exercise intolerance, and fatigue. Sudden cardiac death has been reported. Mild cognitive impairment is observed in up to 70% of patients. Ophthalmological manifestations, including scotomas, blind spots, and blurry vision, have also been described. Additionally, over half of patients, particularly males, report respiratory and gastrointestinal symptoms.
What are the telltale ECG signs of Danon disease, maybe even early on before major symptoms appear?
This is a key point. ECG abnormalities are often present even before patients develop significant symptoms, serving as an important early indicator. A study found that 50% of males and 41% of females exhibited the characteristic shortened PR interval and delta wave of Wolff-Parkinson-White (WPW) syndrome on their ECG. WPW pattern is a common finding in many metabolic heart disorders. The ECG may also reveal abnormal Q waves, atrioventricular blocks, atrial fibrillation, inverted T waves, and notably pronounced signs of left ventricular hypertrophy, LVH. These LVH signs are often evident even in early stages, particularly in males. Severe arrhythmias like ventricular fibrillation, sustained ventricular tachycardia, and cardiac arrest have also been reported. The WPW pattern plus significant LVH should definitely raise suspicion for Danon. Paraclinically, DD patients often show elevated biomarkers like creatine kinase, CK, from muscle involvement and sometimes liver function enzymes, often up to 3 times normal levels. Echocardiography typically reveals left ventricular hypertrophy, often concentric, uniform thickening, usually with preserved ejection fraction initially.
This progresses to dilated cardiomyopathy over time. Interestingly, females may have asymmetric LVH and can present with either hypertrophic or dilated forms. CMR is valuable for assessing the extent of fibrosis and differentiating from other cardiomyopathies. In Danon disease, late gadolinium enhancement, LGE, tends to be diffuse, and importantly, the interventricular septum is usually spared, which can be a distinguishing feature. Electromyography, EMG, to assess muscle function and ophthalmologic assessments should also be performed. Genetic testing for LMP2 mutations is highly recommended for confirmation.
With so many possible manifestations, how do clinicians arrive at a diagnosis? Are there specific criteria?
Yes. Hong and colleagues proposed specific diagnostic criteria distinguishing between men and women due to the X-linked inheritance. For women, diagnosis requires a confirmed LMP2 mutation, plus at least one cardiovascular sign, such as ECG abnormalities like WPW or LVH, late gadolinium enhancement on CMR, LVH on echo, or an ejection fraction under 50%. For men, it requires a confirmed LMP2 mutation plus either one cardiovascular sign as above, or at least one muscular abnormality detected by EMG or elevated biomarkers, or at least one neurocognitive sign like attention deficit or developmental delay. Differential diagnosis includes other metabolic or muscular dystrophies like Pompe disease, Fabry disease, familial hypertrophic cardiomyopathy, Friedreich ataxia, and Duchenne muscular dystrophy. The combination of massive LVH, WPW, myopathy, and cognitive issues is highly suggestive of Danon. Currently, there are no specific guidelines for treating Danon disease itself. Management focuses on the consequences. Heart failure and arrhythmias should be managed according to existing standard guidelines.
ICD placement is recommended for symptomatic patients with non-sustained ventricular tachycardia and syncope, given the high SCD risk. Catheter ablation may be performed to treat the accessory pathway causing the WPW pattern. Heart transplantation is an option for end-stage heart failure, though some studies report poor outcomes in males, potentially due to systemic involvement, with death occurring within a year post-transplant in some series.